What's up, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And I'm Mark.
So, let's introduce Mark. Mark, so you're a physical therapist.
I am.
Why don't
Yeah.
you tell me about some of the core pillars that your practice is based on?
Yeah. So I think a couple of things I try to focus on that I've sort of taken from other people or developed over time that seem to help me develop the um, best relationship with patients that I know that they're improving, so that they know they're improving, are the ability to establish um, baseline measurements, whether that's pain, range of motions, a functional test, taking those baselines that you've established, applying an intervention, and then testing those baselines afterwards to not only show yourself as a clinician that there has been, an improvement, or in some cases worsening, or no effect in whatever you're testing, but also to demonstrate to the patient that, something's happening, something's changing. Um,
Sure.
yeah, along with that, like if you're able to use that intervention, whatever it is, um, it kind of leads into the next tenet that I try and implement, which is the self-management on the patient's part. So it's great if we're able to do something in the clinic, but most of the time, obviously the patient is spending most of their hours outside of the clinic. So equipping them with the tools to be able to manage whatever the issue they're coming to you for is independently, and educating them how to do so, I think is what comes second. How about you? What do you think? Anything that you would add to that? Certain things you do?
No, I thought that those were all really good foundational pieces that
Mm-hmm.
physical therapists and like medical practitioners should all
Right,
pretty
right.
much base their practice on. Now, one of the things that you mentioned were baselines, and
Mm-hmm.
what exactly are the baselines you look to capture for your patients?
Yeah, sure. So I think really easy one off the bat. I mean, it's just subjective reported pain, right? And give them a good 0 to 10, see where they're at, and not only it gives you a general idea. Not really. I'm not as much concerned with you see the standard thing in medical records. What's your pain now? What's the pain at worst? What's the lowest your pain can be? I'm more concerned about what kind of things are you doing where you have pain, and what kind of things that you need to do, whether it's like daily tasks for work, is this pain interrupting you with? And then, like we talked about, you can tie in pain with that baseline with a functional type thing. Let's say someone oh, I have to reach overhead a lot for work. Okay, how much pain do you have with that? To give you a number, 6, 7, whatever it is. Okay, you can use not only the pain score but also their ability to reach overhead. So another thing you can use is the range of motion. Maybe it's painful, it's restricted, so you already have two baselines that you can easily test right off the bat just by talking to the person. Pain score and range of motion. Okay. And then you can tie it back to the individual as well by developing, we'll call it a functional baseline for them reaching overhead at work. Okay. So yeah, a couple easy ones off the bat. Um, Typically, you'll be able to develop those with any kind of patient, right? People are coming to you with pain, right? Typically, whether it's due to the pain or something else, they'll have some kind of movement restriction, right? Yeah, and then just making it personal for the patient, right? Okay, can you show me something that you do daily for work, whatever it is that you find this pain's interrupting you with, and if they're able to demonstrate that kind of movement that they need to do, that's painful or restricted, or it's really interrupting their day to day, and you're able to change that baseline, I mean, you're going to get their attention. So yeah, couple easy ones: pain, range of motion, two easy baselines. I mean, we can talk more about if you really want to nail down, you can talk about. We can look at strength, we can look at power, we can look at reflexes, sensations, stuff like that. But I think the things that get the most people's attention the most are, pain, intensity and location, and the range of motion, and then tying that back to, you said, function.
So it seems like you typically look for comparable signs for your patients.
Yeah.
Um,
Mm-hmm.
it seems like a lot of the things that you're looking for are things that your patient typically will complain of that they're presenting um, with symptoms. Do you find that you have to look for other comparable signs, other ways to provoke their symptoms, or do you usually just go based off of what the patient will tell you when you're getting your history?
Yeah, so you talk more like, let's say they give me, I have this amount of pain. We look at range of motion, stuff like that. You're talking more so maybe utilizing something like, I don't know, tests like a straight leg raise or, upper limb, nerve tension test, things like that.
Yeah, so like
hmm
do you default to checking like neurodynamics? Do
Yeah,
you
sure. I
check?
mean, I try and like, just to keep things consistent, I try and standardize the eval for, obviously there's like slight changes that can be made, but like, yeah, I'll check, if it's relevant, if it's something, let's say someone's coming in, um, with lower extremity pain, thinking maybe it can be spine related. Yeah, I'll do a straight leg raise. Depending on location, maybe we're doing like a femoral nerve test as well. Same thing goes for like upper limb, right? If they have posterior forearm pain, I think maybe some radial nerve involvement. Yeah, we can use those as baselines as well, right? It's just more information we can gather just to determine if we are making a quick change in the person's symptoms. And also, I mean, even though the person, I mean, low chance that the person coming to you knows what a upper limb tension test is looking like. But if you're able to reproduce their specific symptoms with that test, you apply an intervention, have them do some whatever movement it is, and you retest that. Ask them if it feels different afterwards, and they're like, "Oh yeah, it doesn't hurt like it did before. Oh, my arms, higher up, right? I'm only getting a stretch now instead of pain. Yeah, I'm not getting that tingling I was getting before. Yeah, another thing that you can build off of. Yeah, so it's not. It's I guess it's more so. I mean, we talked about the probably the most evident baselines from the patient's perspective is going to be pain, maybe movement. We talked about like their functional, how they're affected functionally due to pain. But if you're able to show them how the a special test or some kind of movement's changed, yeah, you can demonstrate those kind of things to the patient as well, just to have them realize that something's happening.
So I really like what you said when you try to capture a lot of their comparable signs
hmm
as things that they typically come in with, things that they're presenting with, um, their specific issues. I find that if you're having to dig and search for certain things,
hmm
those it becomes a little bit less reliable. And
Sure. Yeah.
for PTs, I feel like we function so much as a salesman in a way where
hmm
we're trying to demonstrate like, oh, this is an immediate change in your symptoms. This is
hmm
telling us we're on the right track. I think that's so important when you're able to kind of change exactly the thing that your patient came in for.
Oh yeah. I mean, it's like it's as if like I don't know. I mean, at least with like when I first started, people come in. I didn't really have this kind of knowledge that I have now about like test retest. Seeing that like you can make like really quick changes, and if these interventions, whatever you're doing are applied correctly, that those changes can be maintained. And at that point, it's the self management just kind of takes control. You're just educating stuff like that. So people would come in for evals, and they have this kind of whatever kind of pain they're coming for. And I sit there and I just oh, I'm gonna just schedule you twice a week for 8 weeks. These things take time, they improve. I'm giving the same kind of interventions to everyone without like much thought, right? So it's yeah, doing these things I think is like it's just so important. Like I'm sure some cases are going to take longer, right? But just like applying the same kind of frequency, similar interventions to every single individual without actually like testing if things are improving and just telling people like, oh yeah, we do twice a week here, and you come in and you do these kind of exercises, and at that point, both the clinician and the patient, they're just you're just flipping a coin. Hopefully, natural history, runs its course and it gets better, and it's just a slow, gradual thing, and then maybe you take I mean, I guess you can take credit for it at that point, under the guise that of under the guise of, or at least the patient is of the understanding that you were helping them when really the probably would have gotten better on its own at that point. Um, But yeah, I mean, I think these things are important. Just just so everyone's on the same page with things. I think not only that is like you talked about the yeah, in our profession, there's like certainly some degree of salesmanship, right? Like, I mean, if someone comes in and their expectation is that maybe they've had PT before, or their expectation is that it's going to help them. I mean, you might not need as much of the salesmanship there because the person's expectation already is that it's probably going to help. Yeah, but in the cases of people who haven't had PT before, maybe haven't had a bad experience, when you're able to demonstrate and repeatedly demonstrate that, hey, we did this and your symptoms got better. Yeah, I mean, you kind of have the person at that point, or at least it's going to help you develop the relationship going forward and hopefully improve your outcomes with them.
Yeah, I think to build off of that, I think what you said before, some patients just get better with time. I
Mm.
think our role is pretty interesting because it's just sometimes you monitor them and you pretty much just try not to mess things up. And that's all that you
Yeah.
have to do. And then the patient naturally will improve on their own. So I think that our job is interesting because a lot of like orthopedic conditions will have the chance to decrease on their own. They may not fully resolve, but they're gonna get better. Our job, I think, is to help expedite that process or to monitor things and to make sure that they're going along that path towards like actually improving on their symptoms instead of just like maintaining or getting worse or anything along the lines of that. I think that is a pretty important distinction. And I also wanted to bring up it seems like when you talk about test retest and how it's like specific to your patient, it really seems like you value tailoring their plan of care and their specific interventions to them as well, and that they're not just getting a cookie cutter program.
Yeah, and the I'm certainly biased towards more the MDT repeated movement styles of intervention. So maybe even like the intervention is similar between people. But as long as I'm able to identify that clinical presentation and know that this movement's going to be right for the person, the yeah, it's individualized to that point because hey, this person's going home with like maybe like a single exercise, but the I think the individualization really comes from understanding the person's their day to day, what they're going through, how they're going to be able to specifically apply this intervention to help them, right? Oh, I get this leg pain when I sit, but I'm at my job I have to sit for 6 hours in a row, and I get it, right? So I mean, there's it makes it harder, it makes it more difficult compared to someone. It's like, oh yeah, I can stand the whole day if I need to and do this exercise every hour or two, whatever. Um, yeah, so like it's not. I mean, yeah, the intervention or the exercise could be, um, maybe it doesn't differ that much, but like the individualization comes from how this person's going to be able to apply it within the scope of their life. And I think like having that discussion with people, like people genuinely seem to value that, right? Like okay, we figured this out in the clinic. We know what makes your pain better. We know what makes it worse. This is what you have to do. So then you can start beginning to speak with them. Okay, would you be able to do this every 2 to 3 hours? 10, 15, or whatever. Depending on their answer, there might need a little bit more thought when it comes to the management perspective. Like, have you found that in your practice, like you have people who, generally, I mean, I'm sure you've had interactions where like you have this discussion and people, it's different for people compared to, maybe other providers they see, not just specific to PT, but just, medical professionals in general.
I do feel like a lot of patients kind of have received that cookie cutter approach where
Mm-hmm.
they don't feel like their concerns are being met or that they're
Yeah,
heard and that
sure.
they're being addressed. I think
Are there
that
any things you've seen like specifically where, um, like how would you know that a patient's not feeling like heard, or do you feel like
so
their needs aren't being addressed?
so usually what I try to do is when I hear like when I ask patients a question when I'm
Mm-hmm.
pretty much getting their history. I try to paraphrase the things that they say and
Okay.
paraphrase back to them, so that
Sure.
way they know that I'm hearing and or that I'm listening and hearing what they're saying, and that I am trying to clarify to make sure um that we're addressing the same point that they're trying to make, because sometimes there can be a little bit of discrepancy between
Mm-hmm.
like what the patient is saying and what you as a medical provider is interpreting it as. So I think that doing so helps both parties be on the same page, and that way if there's a discrepancy it gets met like and addressed early on, like right
Sure.
away,
Yeah. Yeah.
right during the eval, and then you're kind of moving on from there. And I think it's interesting because like we'll say like a cookie cutter approach to a to a specific pathology, right? But
Mm-hmm.
I think that what we are essentially doing is we're giving multiple cookie cutters here, where
Yeah.
we're
Yeah.
essentially just recognizing more patterns and being
Mm-hmm.
more specific with each of the patterns that we're seeing. And so that way we can give them a more targeted intervention that addresses their more specific needs,
Yeah.
rather
Yeah.
than just like throwing a whole bunch of stuff up and seeing whether or not it's working.
Yeah.
Yeah,
Yeah.
I think one of the biggest issues with that is when you do that, if they get better, that's
Mm-hmm.
great, but it's not repeatable. You don't
Yeah.
actually
Sure. Sure.
have that
Sure.
consistency later moving down the road, and that doesn't really help your practice.
I don't think so either. I mean, I like the analogy with like, yeah, it's a cookie cutter, but we have multiple. We have a couple different tools to do it, and we know like we're using each of these. What cookie is that? What those is that what those are called? Cookie cutters? Cookie cut
Yeah,
out things? Yeah. I mean, we got a
yeah,
couple of them, right? If we got the right dough, stick the cutter in, and look, we got our
it
cookie. It
works.
worked. Yeah, we did it. Yeah, compared to like, okay, you have, whatever presentation, um, you test, you get all your baseline measurements, which PTs, do. It's not like people aren't doing evals, right? You come in, you get your range of motion, you get your MMT, you get your pain. Um, but then it's not like the results of the evaluation are driving you towards any certain management strategy, right? It's just kind of like, oh yeah, and you gotta do a couple of stretches, and you gotta stretch your back out, you gotta stretch your elbow, and then you know we'll see how you do. We'll do a couple weeks, and then we'll like retest some things. It's like, you know, I mean, it's not, how should I put it? If we had better data saying like, okay, long term outcomes, like this is exactly how you should be doing something, we could be a bit more um, harsh on people who aren't like test retesting, like within visits. So I guess the typical standard care PT strategy maybe isn't bad, but I just think it can be better, right? Where like especially on the patient's end, right? Like they're spending their time and money to come to you. Um, why not see if you can you said speed up their outcome. Show them within one visit. Hey, you have these symptoms. You're stiff in this direction or whatever. Hey, why don't you do this a couple times? See what happens. Oh yeah, it's not as bad. Versus, yeah, you're kind of tight. I'm gonna print out a paper and give you some exercise and just like try them out, and then you'll come in and we'll do some other ones, and then we'll see if it works after a couple weeks.
Yeah, so I really really agree with that. The biggest thing to me is that test retest is such a powerful tool because it can tell you immediately whether or not something is working, whether
Yeah.
something is not working, and that can help serve as a
hmm
good indicator for you.
Yeah, and we've
My
talked a lot about like the working part, like, and you said not working. So what would you like? Let's say test retest. What can you give us an example of something when it hasn't worked, or how we talked about these baselines. Like, what would you see if you were to apply an intervention and it quote unquote didn't work, didn't give you that favorable response?
Sure. So I think like when you're applying interventions, they should be done to specific like aspects that you're looking
Mm-hmm.
to address? Are we looking to address like joint mobility? Are we
Mm-hmm.
looking to address like the tissue? Are we looking to address strength or their range of motion, etc.? You know, I think the biggest thing that for me when I have something that doesn't work is that I am looking to exhaust that aspect. Where if I think, okay, this person's joint is like my number one like suspicious contributor to
Mm-hmm.
their symptoms, I'm going to apply every single intervention regarding the joint as best as
Mm-hmm.
I can. And then if things don't work, where they're not seeing any improvements, that's definitely telling me something, right? It's telling me that
Sure,
I'm
sure.
not moving in the right direction. And
Mm-hmm.
from then you should be able to cross that off the list and not have to
Right, right.
revisit it. I think when your interventions work, that's great. But
Mm-hmm.
sometimes when you're doing your test retest, you kind of get lost in that where you're like, oh, it's working, it's that's great. And
Yeah.
then it stops working. You're like, well, what do I do now?
Yeah.
Or sometimes when you don't fully exhaust something and you're not sure, you just try a bunch of stuff and something finally sticks. You're like,
Mm-hmm.
oh yeah, that's it. But what if it was the other interventions that were doing some
Yeah,
part?
it gets a little muddy then, right? When you've done so much like that. Yeah.
Yeah.
It has to be like a
So
systematic way of doing it, I think. But yeah. Which
exactly.
I
So
think
I
both of
think
us utilize, but yeah.
yeah, I think
Mm-hmm.
that when you're able to do that, you can take the negative results
Mm-hmm.
and use it to help formulate better clinical decision making.
Right, right. Yeah, I think sometimes too, like let's say you said you start off one with some kind of intervention, you get so far, you plateau, you try a bunch of different other things, and then maybe you get a good response, and then but it's hard to know if that's what's going to be the answer going forward unless it's continuously reproducible, which is something else we can see when you with that standard PT cookie cutter approach, right? It's like, okay, could do a couple exercises. Oh yeah, it feels better, and then but what happens? They come back next time and it's worse. What's your answer then? Oh, well, what made it worse? I don't know. I've been doing exercises. It just for whatever reason bothers me today. If you didn't apply those interventions in a previous visit, and you didn't measure the response immediately after, and now the person says that they are having a different response than when they did the exercise initially. Yeah, well, there was no test retest to begin with, so we don't have any established baseline to be able to compare to. So another way, like things can just get mixed up if we're not, looking for that feedback, measuring mechanical and symptomatic response um, during and after interventions, right? It just things can get weird.
Sure. I think something else about test retest that I think is super powerful
Mm-hmm.
is um I draw a lot of similarities for like PT
Mm-hmm.
alongside of like actually coaching and training
Mm-hmm.
clients and stuff like that, where sometimes you just don't get confirmation that you are moving in the
Mm-hmm.
right direction immediately. You do
Yeah,
not get
sure.
that instant feedback.
So,
Usually it takes
mm-hmm.
like it can take like a few weeks for you to see progress.
Yeah. So,
But
okay, yeah, go ahead. So,
with test retest, you get that you can get that immediate feedback. That
mm-hmm.
is a huge indicator that you're moving in the right
Yeah.
direction. And for the cases where you don't have that,
Mm-hmm.
that's where it's important for you to trust in your clinical decision making. You've already done your due diligence, and then here you've kind of narrowed things down where you're like, okay,
Mm-hmm.
this isn't working. Like I'm not seeing the immediate effect, but I think that we're moving in the right direction, and some things just take time. So I
Yeah.
think that not utilizing test retest kind of shoots ourselves in our foot,
Mm-hmm.
because it's just an aspect that we should definitely be taking advantage of. Like it's essentially just telling us what the right answers are on the test. Who wouldn't want that, you know?
Yeah, and it's so easy to do, right? It's just kind of like, hey, you told me this hurt before. Let's and like we're not when we say, I think when we say apply an intervention, we're not talking specifically any certain thing. It could be anything. It can be anything you want to provide the patient with, or do on your own, right? Um, but like yeah, getting that it should really be something that's integrated into the evaluation, right? You're just not getting the full picture without rechecking these kind of things. It's really interesting to me, and I don't know if you have any input on this, but like it's at least from my perspective, having students like just like in the current PT education process, like it's just not you're taught to test these things, and you're taught what the appropriate interventions would be. You're not taught to test it afterwards, which is just it seems so strange, right? It's like where what happened that and maybe this will change with time, but like it's just weird that you learn how to do an evaluation, you learn how to apply an intervention, but there's not talk of reevaluating what you evaluated after applying the intervention. Maybe it
Yeah,
happens in the future, like a month later, but it's like, who wants to wait a month to get better, right? If it can get better within, a single set of an exercise.
yeah. So that was actually my next point,
Mm-hmm.
which is reevaluations take place like every few visits. It's
Yeah,
like typically for our system, it's like every 10 visits you're
yeah,
doing a
yeah, yeah,
re-eval. And who's gonna wait that long to have confirmation? Should we
yeah,
not
yeah,
be
yeah,
continually reassessing to make sure that we're on the right track? Like,
yeah.
are we actually making progress, or do we need to switch gears
Mm-hmm.
before the 10-week mark?
Yeah,
It
yeah,
just doesn't make
yeah.
sense to me.
And
But
even the thing
it,
too is like, you mentioned the 10 visit thing. It's like, I mean, why are and um tell me and tell people who are listening, why are people doing it at 10 visits? What's the purpose?
but insurance
Yeah, yeah,
purposes
yeah,
at that
exactly,
point.
exactly, exactly. Yeah, it's not like not a single time have I heard a patient walk in and a PT say, "Hey, it's visit 10, so we're gonna do a reevaluation to see how you're doing." Oh, we gotta tell me. Yeah, Medicare says we have to do this every 10 times, so we're gonna do it. Right? It's not. It's. I mean, I'm sure. Yes, people are meaning well. They're concerned for the patient's outcome, but like, have you ever heard it framed like, "Oh, hey, this is visit number 8, so they only gave you 8 visits for this auth, so we gotta, how about, hey, you've come 4 times. Do you mind if we recheck some things today, and then we'll use this note to send for get you more visits too, right? It's just kind of like the framing. It just leads us to it's kind of a giveaway that the um, test retest isn't being done right, or at least
Yeah,
like even when people reevaluate, like they're not doing it to specifically look at those kind of things. Yes, they get remeasured, but they're doing it. Maybe if there was an insurance requirement, it wouldn't get done at all.
that's fair.
Mm-hmm.
That's fair. I
Yeah,
mean, even when you say like every 4 visits, like
yeah,
to
yeah.
me, like we are reassessing every single time we see the patient,
Mm-hmm.
and even then we are reassessing them in within the session. So it's
Oh
like
yeah, yeah.
you should be checking to see how things are progressing, um, with your with each intervention that you're giving. If you're
Mm-hmm.
capturing a baseline before the session begins, try an intervention, capture another baseline, see where that's at. And then after that, you rinse and repeat all throughout. And then you see if the things that you're doing are leading you down the right track. That
Right,
is how
right.
you pretty much um, pick up small wins to help get the patient better. Like
Mm-hmm.
if you just go from first visit on eval to 10th visit and you're like, well, things didn't change,
Yeah, yeah, yeah.
what are
Right.
you gonna do?
Yeah,
But
exactly.
I want to bring it back to your other point. What you were saying is in schools they teach you how to do special tests, to
Mm-hmm.
examine and evaluate a patient, and then after that to give an intervention, but they don't really check to see like how the patient's doing.
Right.
But this is something we've discussed previously,
Mm-hmm.
but the idea of using a special test as a comparable or
Yeah,
as like
true.
your
Mm-hmm.
baseline, you know that it provokes it. So why would we not use it again to see if it improves it?
Yeah. No, I mean, like you're saying, you do the special test first, and I don't know. Let's just say like um sorry, yeah, straight leg raise, something like that, right? Dorsiflex the ankle, they have symptoms. You're talking about like it reproduces the symptoms that they're coming for. You do whatever kind of intervention, you do it again, and it does not, it's less symptomatic, or maybe the symptoms are gone. That's what you're saying?
Yeah, yeah, because like
Yeah, yeah. So like,
if you just
mhm,
give them if you just find that there's neural tension
yeah,
and you give them a nerve glide and
yeah,
then you
yeah, yeah,
send them home and that's
yeah,
it. Well, how do
yeah,
you know that worked?
yeah. Exactly. You don't know. I mean, like, yeah. So let's talk about, yeah. Let's just like use that specific intervention as an example, right? We know that if you got a hot nerve coming in, yeah, nerve glide. I mean, I don't know. It's probably not my um the first thing I would try. I don't think it's yours either, but certainly an appropriate intervention, right? So how do you know? I mean, the dosage is just going to vary so much, right? So like, let's say someone comes in and you just have them, oh, here, do 10. Okay, you're trialing the HEP, right? You do 10. How's it feel? Oh, okay, it feels like about the same. Okay, so now I want you to go home and I want you to do like 3 sets of 10, like 2 to 3 times a day, right? Well, that that certainly didn't trial that, and you didn't have any kind of response. Like I think whatever kind of dosage you want, it has to be um, yeah, exhausted there. Um, but yeah, I mean, so like, we can use these tests. Yeah, it's just I don't, oh, where are you going with that? Because I think it's interesting you bring up the test because it's such a huge focus in school. It's like people know how to, like, you don't have to do any kind of additional learning to be able to do test retest, right?
But yeah, it's just an
Yeah,
aspect of your practice.
yeah, exactly.
I was more or less saying it as just like we find these special tests.
Hmm.
Like if we're the way that we're traditionally trained in school is if there's a cranky shoulder, I am going to put them into a cluster of what their symptoms are kind of presenting as. So
Hmm.
if it's like a rotator cuff issue, or if it's like an impingement issue, or whatever it is,
Right.
and then I'm going to pick various special tests that will provoke their symptoms. But it doesn't really tell me anything other than the fact that I made a cranky shoulder crankier.
Yeah, yeah.
And
It's
so
like,
it really just
yeah,
doesn't
yeah, yeah.
help.
Yeah, it's like I don't even know the name of the test. It's like front of my knee hurts. What hurts if I well, does it hurt if I push on the front of your knee? What is that called? It's the
If you,
patellar one.
the
Yeah, yeah.
Clark sign, the
Yeah,
patellar grind.
yeah, 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 yeah. They have like a first CMC one too. It's like the crazy thing. Like, who came up with this stuff? And it's like, yeah, this is a good idea. But I mean, baselines, maybe. I mean, I guess you could use it. But also, yeah, it's just like, what kind of information is that adding? The person already told you this. It hurts here. Here, if I push more, does it hurt? Right? It's just, yeah, it's odd.
Eh,
Yeah.
the other thing that I just don't like about special tests for a lot of, at least the not so good ones,
Hmm.
are just that they're meant, a lot of them are meant to be provocative. And
Yeah,
so
yeah, yeah.
if someone is already having symptoms,
Hmm.
it's probably going to be more likely to be a false positive. Um or
Sure.
to be
Yeah,
positive, I should
yeah,
say,
yeah, yeah.
because even if they're not symptomatic, they could still be positive for it.
Hmm.
So that
Yeah,
to me
yeah,
is just like, how reliable is it? Does it really make that much sense? And is it
yeah,
really helping us determine a deficit? Because I think that like all PTs can probably agree on this, is that our job is to identify impairments or deficits and to address those. Whether or not we actually like explicitly do it, I think almost everyone will at least agree that that is what they are striving to do in some semblance.
yeah. Absolutely. I mean, I don't want to go too far in this. I think we could do a whole episode on like the when we talk specifically about deficits, but like people like I think this ties back into the beginning when we were speaking about like the using test retest for um activity specific to the individual, right? Like the context of the individual has to be taken into account when you're looking at these impairments and deficits as well, right? Like, hey, maybe for someone's normal for like, bending forward, they're only getting to their knees, right? It doesn't necessarily mean, I mean, we have these quote unquote norms that have been established, right? Like maybe that's normal for that person. Do we have to address it? Is it relevant? I think that just comes more into the evaluation process. But yeah, I think like you talked about the special tests. Like sometimes you get like they can just generally be positive on people who have irritation within like a certain structure, joint, just a general area. So when we're talking test retest, I think we can be simple about it. Pain, movement, right? Things that you learn like the first month you're in PT school. So where's it go? How about like what we mentioned, self management as well, right? So another important thing, you got your baselines, you did your intervention in the clinic, you had your outcome. Where do you start when it comes to having the person begin to manage on themselves? Like, are you having them do, um, you know, all the exercise in the clinic before they leave at the eval? Are what's it look like? And, what have you found seems to work or make the self-management components stick?
Yeah, so I think the test retest really ties into the salesmanship of this,
Yeah.
is because if I can prove to you that I am changing your symptoms for the better,
Mm-hmm.
you're probably gonna do your
Sure,
exercise
sure,
because
sure.
you want to get better, and
Yeah,
now you have concrete proof that it is getting better
yeah,
within seconds.
yeah.
The,
Especially,
the biggest
yeah. Go ahead. Yeah.
but the biggest thing is if there's carryover,
Okay.
and that
Yeah.
is where, like, when I give an intervention um on eval, I give very very few things for their HEP.
Mm-hmm.
I give like one, maybe two exercises tops, for something that, like, if I have a pretty good feeling of what that I know what it is, that's all that I'm going to give, because I want to see how much of an effect that it has. And if it doesn't change at all, then that means that the test retest that we saw in the clinic, that improved, is fleeting, that there's no
Mm-hmm.
carryover, and that's okay. It just tells me that now with time that didn't change, and
Yeah.
now we have to
Yeah.
go back
A little
and
more
address
information
that.
you can work with, right?
For sure, for
And you
sure.
still have
Uh,
your eval baselines, right? So then you can just retest baselines again. Maybe they come in and they're like, it feels about the same, right? But maybe they're, um, you know, maybe they were limited to a certain, let's just say, cervical extension. They were like 75% limited. They come in, maybe they're near full, right? It's like, okay, well, maybe it wasn't clear to them, but you have your baselines, everything you looked at the first time. That's something you can build off of. Where if you're not like measuring and retesting these things, like we mentioned before, it's just like you get lost easily, right?
yeah, and I feel as if when you are giving um interventions for patients to do at home, they do not want to do a lot of
No, yeah,
things.
people are busy. They got stuff to
They
do, right?
Yeah, they just, like, there are so many times I remember, like, even when I was previously a patient or anything like that, you start with like a list of 3 to 5 exercises on
Mm-hmm.
evaluation, and then as you continue with your sessions, you just keep adding more and more and
Yeah,
more
yeah,
and more, and now you have like 20, 30
yeah, and
exercises by the time that you're
yeah,
done.
yeah,
And you're just like, what do I get rid of? What do
yeah.
I do? I stopped doing this. I supposed to stop?
Yeah, yeah. You get the
Like,
questions like, "Do I still do the ones from the first time?" Yeah, sure, I guess. Why not?
so
Yeah.
it's just
I
like,
mean, here's the crazy
how.
part. That some people do it. Some people. I mean, you had people come in with like a recurrent issue. Maybe you haven't seen them before, and they have like a packet or a folder. Like, oh, when I went to PT last time, these are the ones they gave me. You want to look at them? And it's like 4 or 5 pages long, and you're like, maybe next time. You're right. It's just like, I mean, some people do it, but like, I mean, I think most people aren't going to.
Yeah,
But
I think it's, to me, it's actually helpful to look at those exercises
yeah,
that
yeah,
they did
everything you see.
previously,
Yeah.
because if nothing changed, like, this is actually a question that I utilized pretty often now when I'm gathering their history, is, have you had PT for this before?
Yeah, yeah.
If yes, what did they do? Did it help or did it
Hmm.
not help?
Yeah.
And then that's usually when they tell me, oh, I had a great experience. My back pain was resolved after blah 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 blah, or that was a terrible experience, nothing helped, my pain
Hmm.
got worse actually, and so now I know what to do, what not to do, and I also know some of my patients' biases too,
Yeah,
and that
yeah, yeah,
makes it a whole lot
definitely.
easier to like get buy-in from your patient on what your treatment method should
Right.
next be.
So what does it look like for you if um what if, like, we talk about self-management, we talk about home exercise program. What if you have a patient come in, you try whatever kind of, exercises they're doing. What's the self-management component look like for you if the only thing that changed their symptoms initially was like a hands-on manual technique? Um, do you try some exercise afterwards to see if it helped? Do you, even if they weren't getting a necessarily beneficial effect from a specific exercise on their own, do you still try to work something in at home? Or yeah, tell us about that.
Oh man,
Because
that's a
it
good
can
question.
get weird, right? Because especially like, we're talking about test retest, we're talking about self management, right? I'm sure it's making sense to people. It's like, yeah, let's check these things. Let's, like, and we're talking it within the context of the patient being able to change it on their own, right? In that case, the self management component is clear. We know what they have to do. So, but what's it look like if, what if you had to what if you had to put your hands on? What if you had to, work into it your own? How do you prescribe self management in that situation?
Yeah, so that is definitely a good question. So that is probably why my practice has
Sorry.
changed so much from
Mm-hmm.
the beginning to now. Is because if a patient is reliant on me to get them feeling better, they will not stop coming in.
Mm-hmm.
So to me, I have a couple of things that I do because I still enjoy manual techniques.
Yeah.
And one of the big things is, do I need to put my hands on them?
Mm-hmm.
Or am I able to achieve the same goal without doing so?
So you
The
mean,
the
so
sec
like you're at the eval, you've already done the manual technique, and then you're determining after that if you need to continue to
Oh,
do it, or you're thinking, or is this
no, no,
before
no,
you get?
no.
Okay, yeah, yeah,
Before I even do
okay,
the manual
gotcha. Yep,
intervention.
yep,
I will try it without me having to do anything to see how does it look. Are we
yeah,
producing
right, okay,
the same
yep,
effect that I'm looking for and
mm-hmm.
stuff like that? If we are, that's awesome. That's self-management. They're
Yeah,
able
you're
to
good,
do the
right,
stuff on their own, and then it's not passive anymore.
mm-hmm.
The issue becomes when I have a patient and they're not responding to anything else. Well, and let's just say that they genuinely are improving with manuals and that they're not just looking to not do anything for the session,
Mm-hmm.
right?
Mm-hmm.
So let's say they do improve with that. My next thing is to reinforce it right away. So if we're able to make changes and then after that we can reinforce that pattern that I'm looking to improve on, if that stays pain free, that is the movement that we're going to continue to do
Mm-hmm.
for when they're at home. And usually like for manuals it's going to be like some mobility or soft tissue work, and that way they can continue to do that for themselves when they're at home and
Oh,
couple
interesting.
that
Okay,
with reinforcement.
so you try and
So
teach them to reproduce the manual effect, whether it's
so
like
if
a,
it's
yeah, mm-hmm.
if possible, yeah. So like
Okay, okay,
I think like a good example of this is like if we are doing like repeated extension in lying
mm-hmm.
with clinician overpressure,
Yeah,
they can't replicate that at home. They can't replicate a mob at home. So what I try to do is get if I mob them and they improve in their symptom presentation, and then I have them regress their force,
mm-hmm.
and it actually continues to improve or stay
Yeah,
improved,
mm-hmm.
and they're able to do that at home, that's what they're going home with. Or for clinician overpressure, if they're able to do it with a belt to
Okay,
help
yeah,
give them a little bit more force, then that's awesome.
yeah,
That it
okay,
doesn't simulate the same thing that I'm doing, but it's close enough. It's
yeah,
something that they
yeah,
can
yeah,
still
exactly.
do when they're at home.
Okay. Let's say you do your initial clinician overpressure, you retest, um, um, let's just say like a self overpressure, repeat extension line of self overpressure. They're able to improve with that. You got them over that initial hump with the increased force, and they can continue it on their own. But if you find that they still require the higher degree of force, you're finding a way for them to replicate the manual technique on their own.
Yes,
Yeah,
because
gotcha.
I
Okay, okay,
think
yeah.
I
Versus
think
like,
for
let's
the
say like you do the manual and they improve, and then you know,
that's it.
yeah, and it's like, okay, well here you can go ahead and do your press ups at home, and we'll see what happens, right? But well, we've already determined they need the higher level of force. Okay, yeah, gotcha. So you find a
Yeah,
way to
so
try and get them reproduce the manual technique if
yeah,
possible.
so
Yeah.
that's typically what I would do. And I think determining whether your patient needs that, like truly needs it, is different, and that's why I like having so many different tools available to me, is because there are times
Mm-hmm.
where if I'm able to fix their issue right away with my hands, awesome. I'll just do
Mm-hmm.
that. But I can't always do that for people, But
Yeah.
if they respond to something that they do on their own, that's
Mm-hmm.
something that they can take home with them.
Yeah.
And I
Right.
want to make sure that they're able to draw that connection of, oh,
Mm-hmm.
I do this and I feel better, therefore I'm gonna do
Yeah.
it,
Yeah.
whether or not it's like by
Right.
me, and then showing them how to replicate it, or
Mm-hmm.
something that they can just do all on their own.
Sure. Yeah. So you're not, or are there ever any cases where you're doing a manual on the eval, and then you're not giving them a self management component?
It is very rare that I actually
Yeah.
do a manual in during the eval.
Okay.
That is
Yeah.
not my
Gotcha. Okay.
first thing
Okay.
that I typically
Yeah.
go
So
to.
you're emphasizing self management by essentially like presenting it not as the only option at the eval, but like the understanding is that the patient is going to be able to manage it on their own
Yeah,
at
so
the eval at
that's
least.
where
Yeah.
I try to put the patient in the driver's seat,
Hmm.
because if I am responsible for all aspects of their health, that's not really fair to the patient nor to me.
Yeah.
So I want to make sure that they are holding themselves accountable, and that they understand this is something they're in control of. And I think that control and autonomy is so important, because when you have that perspective, that's how you get better. But if you feel like I have to rely on XYZ to get me
Hmm.
better, then it becomes a much more like, you kind of pigeonhole yourself
Yeah.
into
Yeah.
the kind of care that you're able to receive.
I mean, I had this experience, I think, in my first year treating where this guy came in, thoracic spine type pain, say like subacute type thing, and I didn't really know where to go with it. Did some mobs, he felt better, and then because I wasn't able to um, really figure out how to work in the self management component, most of his session was like manual type stuff, and then by the time he was feeling good, I was like, hey, you ready for discharge? You haven't had pain. You're doing good. He's like, well, how am I going to do the thing you do pushing on my back? I was like, good question, man. I don't know. But the problem is, yeah, self management wasn't ever like, it wasn't not that it wasn't discussed, but I mean, it wasn't something that I was able to demonstrate to him that he would be able to do, right? So it was just kind of like, well, you're not going to be pushing my back anymore. So what if it starts to hurt again? And it's like, yeah, I mean, that's a fair question because he hadn't been to PT before, so his understanding of PT was coming from me, and it was me pushing on his back, right? Well, can't do that at home. Um, yeah. So okay. So the emphasis on the you said putting the patient in the driver's seat from the beginning, something you do, and then the manual stuff can come after if you find it's necessary.
Yeah, and even if it's like for a spine patient, for example,
Mm-hmm.
if they require like an extension mobilization, for
Mm-hmm.
example, I can do that in the clinic, but I'm gonna send them home with a regressed version, because they're
Yeah.
already
Yeah. Yeah.
responding to extension exercises, or they have a preference to it, right?
Mm-hmm.
So that I don't think is going to hurt by any means of the word. But if they're responding to extension already, like to me, we're either going to get like a net neutral, or we're going to get a positive
Yeah,
out of it.
yeah,
I
yeah, yeah.
highly
Right.
doubt that it would actually do anything that would worsen their symptoms. So I'm totally okay with transitioning them from me mobbing them to giving them something that they can do for when they're at home.
Yeah, especially like let's say you're only getting the within intra-session effect symptomatic response with the higher level of force with the mobilization. Like who's to say that if they don't do, maybe they let's say they, they do repeat extension lying, 6 times a day for the next week until you see them next. Maybe they have a cumulative overtime effect with that, right? It just wasn't um, demonstrated well within the session, right? So yeah, exactly like you said, they're probably not going to get worse from it. If anything, it's neutral, and then you need a little bit more force as they're coming in. But right.
Yeah, and that way you've actually already developed and reinforced that habit of
Mm-hmm.
doing your HEP and staying consistent with it, which I
Yeah.
think is very hard for those who have a directional preference.
Mm-hmm.
Which also reminds me, and it's a good segue for the next episode,
Mm-hmm.
is that we talked a little bit about MDT
Yeah.
and McKenzie principles. But I think next episode we can actually talk more about them and how we utilize them in practice and whatnot.
Yeah. I was just gonna touch on too, like for those who are listening, like we're talking a lot of this test retest. Kane and I both. I think our go-tos are, MDT, McKenzie, repeated movement, sustained positions type stuff, just to go off because it already has a built-in test retest component. It's essentially like the hallmark of the system. But this test retest stuff, like you can retest strength, you can ask the person their pain, you can retest range of motion, you can retest joint mobility, power, whatever it is, regardless of the intervention you're applying. Um, so you don't have to do McKenzie MDT stuff to be able to utilize test retest and to utilize self management, but just it doesn't really matter the kind of intervention you're using. It's just these principles we talked about. Yeah, Kane. Anything else you want to add, or do you think we're good to wrap up? Anything you want to throw in, or I'll just summarize
No,
some things. Mm-hmm.
I think that this was a pretty good discussion.
Mm-hmm.
I think that one of the bigger things that we wanted to jump into was like the foundation of your practice
Right.
and why they are core to your formulation of like
Mm-hmm.
why you do the things the way that you do them. And so I think that it serves as like a very sound foundation for a lot for your practice and for a lot of other people
Mm-hmm.
to kind of see like, oh, this is how we can start to incorporate these things and utilize them to
Right.
improve on our
Yeah.
practice and to have more consistent results. I think that's like the
Mm-hmm.
biggest thing, is having um improved results, but also making it consistent and reliable instead of just like,
Yeah.
oh,
Yeah.
I guess we got lucky.
Yeah. It's like, oh yeah, you got better, and also I did these same exercises for someone that had a completely different presentation as you, and this person also kind of got better, but it was different, and I don't know why, right?
Yeah, I
Right.
think it just gives us a better understanding and appreciation
Mm-hmm.
for different conditions and presentations that a patient can have.
Yeah, for sure. So yeah, just to summarize then for everyone, like this test retesting, the barrier of entry is extremely low. All you have to do is you do your eval, not your whole eval. You retest the relevant, objective, subjective pain, and functional measures that are affecting the person after you apply the intervention. And after you apply the intervention, you just got to tailor the self management to the individual, right? You got to have the conversation. Walk me through your day. Are you going to be able to do this? When you wake up, you're going to be able to when you go, right before you go to bed, right? What's it looking like? Um, but those two things, easy to implement. It's something you can go to the clinic tomorrow and start with right away. It's going to give you some more information on your patient. It's going to give you a better idea of what kind of interventions are going to work for different presentations. And I mean, I think Kane and I both believe it's had a great impact on both of our practices, and we hope the same for you. All right,
All
that
right.
is it for today. All right, we'll
All
see you
right.
on next episode, everyone. Bye bye.